about ultrasound of the bowel, the intestines, and normally when you think about ultrasound of the bowel, you think about air being the enemy of ultrasound, and certainly on a guy like this, it would be pretty tough to do an ultrasound. However, I would argue that guy, even though he's smiling here, if he wasn't smiling, I'd worry about a bowel obstruction. And I think you'll see here that ultrasound for bowel obstructions is actually really accurate and is an excellent modality here. And I'm going to try to make that argument. And then I'm going to talk about appendicitis, one of my favorite topics of all, because I really think that ultrasound for appendicitis, we really offer our patients so much in terms of avoiding an unnecessary CT scan, expediting the care, and also it does put our sonographic skills to the test. So it's sort of a worthy opponent, if you will. Normal intestine, you don't really ever see it, right? It's just kind of doing its thing. There's air in it, air being the enemy of ultrasound. And normal intestines is sort of pesky. It gets in the way. You have to push down on it. The normal loops of bowel kind of float out of the way. When you're on your way to find something like, you know, the aorta or the bladder or the uterus or something like that, the bowel's in your way, and normally it just kind of floats out of the way on you. And that's good. In fact, if you look at the top image there, that's just normal layered appearance of bowel. If we put the transducer on ourselves right now, that's probably what we would see. You can actually see sometimes in the short axis over here, when the bowel is sort of mid-peristalsis and there's no air in its lumen, you can make out the outer wall being very hypoechoic and that inner submucosal area being very hyperechoic, and that's normal. That's what we expect to see once the air is out of the way and you can see it. Normal intestinal wall itself depends on large bowel or small bowel, but you're talking about millimeters for the wall, you know, 3 or 4 millimeters. And in terms of intestinal lumen, it's probably 3 centimeters is really where we draw the line in terms of the maximum luminal distensibility that you'd see before you're really thinking about some kind of ileus or obstruction. So, but to try to hit this point home between small bowel and large bowel, small bowel is really cool looking. It has all the plicae circularis, and as I mentioned, you've got these 4 layers of the bowel wall. Not that critical to know, except this submucosal thing. That's going to come into play later in my talk. I just want you to be aware of it. That's one of the 4 layers, is this submucosal. So you got the serosal layer, the muscularis externa, the submucosa, and then the mucosal here. And the plicae circularis, it has these rings in the lumen of the bowel. You can see them here in this 3-dimensional drawing. And you can see them sometimes if you do have a small bowel obstruction. You'll see the plicae stretching out across the screen as you get towards the edge of the bowel. You're sort of off the center of its axis, off to the edge of it, and you'll see the plicae over there. As opposed to large intestine where you get these haustra, okay? The haustra are these little areas, these folds that come down here. And again, normally you don't see them unless there's some kind of colonic obstruction where there's fluid displacing some of the air. And that's really why ultrasound is so good for small bowel obstructions, is because when you have pathology here, you have fluid replace the air, and then boom, everything just lights up like a Christmas tree. It's beautiful. So these are 2 examples here. In both of these situations, there was an obstruction. On the left, there was a colonic obstruction. On the right was a small bowel obstruction. And I just wanted to point these 2 things out to you, large and small intestine. Now, which transducer are you going to use when you're looking at the intestines? I would say I like that big curvilinear probe with all of the elements in it. A little lower frequency, it's good for penetration, gets through a larger individual. But when you're working with people with less smaller body habitus, then you want to try to use this linear transducer, take advantage of its high frequency and its beautiful resolution. So if I had 2 linear transducers, one with a higher frequency bandwidth, I'd be thinking about, you know, for eyeballs and testicles, whereas something with a lower frequency bandwidth, like for a DVT linear transducer, that's the one I would reach for doing appendiceal or bowel ultrasound. It's nice if you're lucky enough to have 2 linears that way. But if not, grab any old linear and turn the frequency down on it and start looking around. In the linear case for the appendicitis, For the curved transducer, that's really where I start looking for small bowel obstructions. So I usually start with that curved transducer. Yes?
So do you have a particular preference for preset on that linear probe?
Yeah, that's a good question. I like the DVT preset on the linear probe when I'm looking around for appendicitis, because it's a lower, it tends to be a lower frequency bandwidth on the DVT preset, because it's trying to get down to a deeper venous structure. So that's, in general, that's not a rule or a guideline or anything like that. You could try different settings, see which one you like better. A small part setting sometimes is okay too. So yeah, you try to get away with linear, particularly with appendicitis. Now, here's a question. This is a board examination question. It's on the emergency medicine boards. I know you're not supposed to retell the questions, but I couldn't help it for this one because it was such a great question. Probably one of the best questions ever written on the emergency medicine board. What imaging modality has the highest positive likelihood ratio for small bowel obstruction? And I think most people would get this wrong and put CT or MRI, but the answer is actually ultrasound. It's got the highest likelihood ratio, positive likelihood ratio for the diagnosis of small bowel obstruction. And as you can see here on this image of a small bowel obstruction, this hyperperistaltic, and the stool and the fluid in there, the contents going to and fro, that to and fro nature, or you could say poo and fro if you want to be funny. So we say poo and fro in my emergency department. The patients, they're vomiting, they're kind of smiling when you say that. But this is what it looks like here. This is what a small bowel obstruction looks like. Again, that fluid replaced the air, and it's like so easy to see. I'm going to show you why ultrasound here, hopefully, is the test of choice, in my opinion. The study in this academic emergency medicine, one of our higher tier journals, very respected journal, got published, and basically what they did was they looked at, for small bowel obstruction, they looked at factors like history and physical examination, x-rays, which of course we know are useless, CT and MRI, and ultrasound. If you look at the likelihood ratios here, and you look at CT and MRI for small bowel obstruction, you're looking at positive likelihood ratios of 3.6 and 6.7, but when it comes down to ultrasound, had a crazy likelihood ratio of 14.1. So almost double that of MRI. So I think that's really important. This is what it looks like here. We call this the keyboard sign. You can see the plicae circularis here. When you're mid-axis, right over the center, the lumen of the bowel here, mid-axis, you'll just see the edges of these keyboards here, these keys. That's the plicae coming up on a small bowel obstruction there. Very easy to see. You flop the probe down, you get your answer in seconds. I mean, and you can trace it around to look for where the transition zone is between normal bowel and obstructed bowel. And so that's one of the other advantages. This has this real-time, you're almost utilizing it as you're examining the patient. You're pushing around and you're finding, all of a sudden you find this location where that goes away and you're back to seeing the normal layered appearance of bowel. And then you move the probe a little bit and boom, there's your obstruction. And you're saying, hey, I think I'm seeing a transition zone down here in this particular quadrant of the abdomen. So that's another reason why this is a good test. But you can see here the poo and fro going on. Here's another, they all start to look the same after a while if you do a bunch of these. So I'm going to just kind of flash through a few of these quickly here. Here's another one here. Just loops of bowel that are obstructed as you're examining this patient. Maybe once in a while you might see a little wedge or a wedge of free fluid seen right there. There's a little micro perforation there, maybe some free fluid. Another example of another bowel obstruction here. They call this the keyboard sign. When you get mid-position on a small bowel, you'll see these little plicae down here. Some people call that the keyboard. They're like little keys on a keyboard to some people. Some more poo and fro for you here. Classic small bowel obstruction. If you look over here, you're at your centimeters. You got this is 2.5, 3 centimeters. Right when you get to about 3 centimeters, that's when this is. And you're seeing that back and forth there with the distended loop of bowel. When you're mid-position, you measure it. If it's 2.5, 3 centimeters, you're there for the diagnosis. This patient has a bunch of ascites up here adjacent to their small bowel obstruction. You can see it, so these loops of bowel here floating within the ascites. Another example here, again, all the keyboard sign of the plicae coming around here, distended loop of bowel here, with the fluid-filled loop of bowel. Another example. Here's all this fluid in here and the keyboard sign. I mean, I have so many examples of small bowel obstructions. I could go on all day long about it. And so and there's been some other studies since the one you saw there, but suffice it to say, if you're not using this for small bowel obstructions, I think it's definitely one of the easier, low-hanging fruit to pick off pathology-wise, and you do feel pretty excited when you see it. I'm going to talk, let me go back for a second. Any questions about small bowel obstructions before I move on and talk about appendicitis?
Max, will your surgeons accept a referral on an ultrasound without paying for them through a CT?
Great question. Will our surgeons accept a referral for just an ultrasound and not a CT scan? And it depends on the surgeon. I can get the patient admitted to the hospital to a surgical service based on our point-of-care ultrasound for a whole host of surgical conditions. Some of my attendings don't feel as confident with ultrasound, and they don't even bother the surgeon until they get a CT scan. So it all depends on we are credentialed by the hospital to interpret our own point-of-care ultrasounds, and intestinal ultrasound is one of the areas of credentialing. So, and it's in the medical imaging system for the hospital. So, and we have a report. So it looks pretty legit, I think, to the people upstairs. However, some of the surgeons just are very old school. They want a CT scan on all these patients. So, you know, but at least I got a bed. I got the patient to the right service. They're going that direction. And we've got the NG tube placed, and sometimes some of these decompress a little bit by the time they get to CT scan frame. Yes?
I think when I was at a conference that you presented in the US, you taught medical students and you sent them off into the ED to look at query bowel obstruction patients, and they had a 80% roughly sensitivity. So I think I gathered from that it's pretty easy to teach.
Yeah, so my medical students, if I could brag about them for a second, they get sort of over-engineered with their ultrasound skills. Okay, it's like the first 2 years of medical school, where they're learning all the stuff in the classroom, we hit them with 14 separate sessions in those first 2 years before they even go off to see a patient. And it's all flipped class, it's all podcast, and then it's all, when they come to class, it's all hands-on. And so they get, especially in the second year, they see a ton of pathology clips, so they get pretty good. So by the time they get to the third year, it's kind of a thing, like an attending surgeon will say to a third-year medical student, go find the appendix for me. Show me the small bowel obstruction. It's like this thing in my hospital. So it's kind of a weird environment that way, but I also think it's a nice snapshot of what could be at other places if you did over-engineer these medical students for this thing. And by the way, I should say that if anybody's interested in my curriculum at the medical school, or any like lectures that you've seen here, just bring me a thumb drive or hard drive and I'll just download all my stuff to you. It's all open source access anyway, so whatever you need, any of that, you can have it. Other questions about bowel obstruction before we go to appendicitis? Okay, appendicitis is an art. I love it. It can be very challenging. You know, you're in that right lower quadrant, linear transducer, compressing, you're looking around for that psoas, you're trying to get the abdominal wall to come down to that psoas muscle, and then all of a sudden, boom, it peeks its head out, and then it's gone. And then you're like, oh man, I gotta get back to that, and then you back up a little bit, and you're like, I saw it over here somewhere, and compressing, and you're really looking for that non-compressible tubular structure that's got, so, you know, depending on the time course of the appendicitis, it may or may not have other things like periappendiceal fat or the three-ring walled appearance. I'll get into that in a minute. But what causes appendicitis many times is a blockage of the appendix itself with a fecalith or an appendicolith, it's called. Basically a little poop stone that blocks the opening to the appendix, and then it can't drain its contents, it starts to swell, and then the pressure inside the appendix outweighs the ability for the venous drainage, and then you get perforation. So, normal appendix, I know they're hard to find, but you take a medical student and you put them with a healthy model, and then you walk away, give them a half an hour, they'll find it. It's time. This is time. This is patience and time, and you can find a normal appendix. It's just that we don't have a half an hour. We're working in the ER. It's impossible. So if it's not positive, we usually walk away and say appendix not visualized, and then we turn to another test. We turn to basically CT scans. So, or maybe it's reevaluate the patient in 6 to 8 hours, depending on how curious you were about the diagnosis of appendicitis. So, but feast your eyes on some normal appendices here. This is the psoas muscle. This is the abdominal wall musculature here. Okay, we see another abdominal wall muscle. And what you're doing is you're compressing the psoas to the abdominal wall musculature. They come together and they make the appendix pop out. This is the iliac vessel right here, psoas. You're really looking for the psoas. And pushing the abdominal wall down. Here's your abdominal wall musculature. Here's your normal appendix coming along here. Your psoas is down here. A little bit undergained in the far field. Hard to see psoas, but that's the idea. We see some iliac vessels here and see the nose of this normal appendix. It's in a longitudinal plane here coming across. Beautiful example of a normal appendix there. You guys see that? It's a game of compression. Here's psoas, beautiful psoas muscle here. And there's another normal appendix right here. We're just compressing abdominal wall down to psoas, and that appendix kind of squirts in and out of the plane there. It takes a sharp eye to see it, but you'll pick them up if you take enough time to do that. Now, that's the idea. We just keep compressing until we can see these normal appendices come across here. All psoas muscle down here. And this is, anybody know what this is right here? When I first saw this, I thought it was the appendix. I was like, oh, look, appendicitis. No. Yeah, terminal ileum. Looks like that when it's devoid of air, you can see its redundancy there. It looks like a little sand dollar or flower or something. You see it there. The TI or terminal ileum, that's a cool landmark because you know the appendix is not far away. And so you start, going around the TI to try to find the appendix. And the appendix, can go in all different. It can come off and go anywhere it wants to. And so that's the trick, that's the art of all this. And so I can't say, oh, there's the TI, go medial or go lateral. You're in the right area, now you gotta look around a little bit more. That's the idea. But you see above the TI, this is all abdominal wall musculature. It could be rectus abdominis muscle or abdominal oblique. Doesn't really matter, it's abdominal. And then the peritoneal lining is right here, just below that abdominal muscle. Here's acute appendicitis. We see it down here. It's non-compressible tubular structure that is in the right lower quadrant. Here's psoas below it, abdominal wall above it. Gets wedged in there. This one happened to be 1.1 centimeters. But it's, some people say non-ovoid, or it's round, or it's non-compressible. Ways to think about it. This is kind of what happens. I just compress. Here's psoas here. I'm compressing it. I just don't see the appendix. This is a pretty... I spend 3 or 4 minutes looking for the appendix. I don't see it. I give up. I go to another patient. If I had a medical student around me, though, I'd say, hey, go in there and hang out for half an hour, see if you can find it. It depends how uncomfortable the patient is. There could be something else going on. If it's female, I'm definitely going to consider an endocavitary ultrasound. Look at the adnexa. But this is the idea. You're compressing loops of bowel as you're marching around in that right lower quadrant. I hand the transducer to the patient. I say, put the probe where the most pain is. And they put it like right over their appendix sometimes. They show me the diagnosis sometimes. Here is an appendicolith. You can see it right here. It is blocking the takeoff to the appendix. The appendix is coming out this way. And then boom, looks just like any other stone you see in the body with the shadow and everything. When you do have an inflamed appendix, you get this round, non-ovoid, non-compressible tubular structure, and then you get some hyperemia going there, so you get what we call a ring of fire. There's more vasculature going to this inflamed structure. So when you get that ring of fire, it shows that you have active inflammation going on here, and it looks pretty. I don't know how prognostic it is for having a more complicated appendicitis or not, but it's pretty to see. You see these rings of fire. You can actually see this one with the vascular stalk going to it. Next door, I like the terminal ileum here. I like the TI over here as well, adjacent to our appendix on this one up here. All 4 of these pictures here is all pediatric appendicitis. These were all kids. We found these in. But you can see this one in particular has a very nice submucosal, very prominent submucosal layer. Here's some periappendiceal fat right here, hyperechoic periappendiceal fat. Perhaps some more periappendiceal fat here. Yep, here's psoas down here, and then abdominal wall musculature up here. That's a really pretty one here. This is in a longitudinal plane with its appendiculate seen here as well. Okay. Now, so I looked around the literature and I tried to find in what is the real criteria to prognosticate some of these appendiceal structures. What are the radiologists talking about? What are the real experts, the sonographers, pediatric sonographers talking about here? Because in some pediatric centers, you get these pediatric sonographers and they are absolutely obsessed with the art of appendiceal ultrasound. And then they write about it, and then that's how I learned so much about it. So this one reviewed the literature, and then they looked at some common diagnostic criteria for acute appendicitis to predict the presence of disease or prognosticate the disease. And so they did review the literature. They found 246 right lower quadrant ultrasounds. They did some statistics on it, and they figured out that in this particular study that periappendiceal fat was the only statistically significant finding for acute appendicitis with an odds ratio of 68, a significant p-value. So periappendiceal fat, really, really important. When you see that, you're looking at appendicitis. Other criteria, at least statistically from these 246 patients that they looked at in this study, there's no independent predictor there. They were important but not independently predicted. This is from the article itself. You can see around the normal fat, this patient had appendicitis, but not a lot of periappendiceal fat. Or it had a fat, but it wasn't inflamed. When the fat gets really fuzzy and echogenic, they described it as fuzzy and echogenic, that's periappendiceal inflammation, fatty inflammation, basically. So can you see those two structures? This looks like more of a striated appearance over here, this fat. This fat looks more fuzzy and harder to discern. Rings. Yeah, early appendicitis, you've got all three rings here, the mucosal, submucosal, etc. Over here, you only got a couple rings, and so you're getting more to an acute stage. And over here, there's only one ring left. And another article you're going to see argues that if you lose that submucosal hyperechoic ring, that is, now you move from uncomplicated to complicated appendicitis. So think about those rings. Here's some appendiculates. And here's your periappendiceal fat. Again, it's from this article. You can see that fuzzy, hyperechoic fat here surrounding the appendix as it's coming down here. And then finally, this article here looked at that loss of that echogenic submucosal layer. That's what really discriminated complicated from uncomplicated appendicitis. And so you can see from their article, one of their figures is a 14-year-old female, uncomplicated appendicitis, and you can see the submucosal layer. Why do you think it's important to distinguish between uncomplicated and complicated appendicitis? Who cares? Appendicitis is appendicitis, right? There's a lot of people now, there's a big trend towards giving antibiotics, and so if you see a really nice submucosal layer there, very hyperechoic inner wall, maybe that's a patient that, you know, depending on where you work and the situation you're in and your surgeons and all these factors, that might be somebody who gets IV antibiotics and gets watched for 12 or 24 hours and maybe avoids a trip to the theater. Okay? How about this one here? This one is a 19-year-old male with gangrenous appendicitis, and you can see there's really no submucosal layer. It's kind of gone. You know, I don't know where they photoshopped it out, but it looks beautiful. There's nothing here. It's just kind of like this tube that's non-compressible that doesn't have those layers. It's missing that inner submucosal hyperechoic layer. And this was an interesting one here. This is an 18-year-old female. They said, she's got some submucosal layer over here, but this is complicated appendicitis with a periappendiceal abscess from loss of that hyperechoic submucosal layer as you come along here, and then perforation into where the abscess was. They said this is where the perforation likely occurred. But you can see there's submucosal layer here, and then boom, it's gone, and then there's perforation. So again, when you find the appendix, don't just give up, but really look at it and look at it in different planes. Try to trace its submucosal layer around. You might be able to strategize which ones are sicker than others. And so this one here, this is some periappendiceal fat I see right here. But there's a pretty good submucosal layer here. So this is acute appendicitis. I see periappendiceal fat, as well as this one here. Again, on this same patient, but now I can see the fat all the way around it over here as well. Periappendiceal fat on this moving clip. with a nice submucosal layer. So in this case, yeah, it's acute appendicitis, good submucosal layer. Depending on the situation, may end up getting IV antibiotics, depending on my surgeon, my institution, all those things. Here's another patient with appendicitis, nice, several layers. You definitely see the submucosal layer here, some periappendiceal fat, right here, periappendiceal fat. I like this. This is classic acute appendicitis. With that submucosal layer intact, I think this is probably uncomplicated appendicitis, and with some nice flow around it. And with that, basically concludes my lecture. Non-compressible, 6 millimeters, tubular structure in that right lower quadrant. Gets sandwiched between your abdominal muscle and your psoas. Sometimes you see an appendiculate. Periappendiceal fat, acute appendicitis. Loss of submucosal ring, complicated appendicitis. And finally, ultrasound for small bowel obstruction, highest likelihood ratio than any other imaging modality. Questions? Yes?
Could you just talk a little bit about other than putting the probe where it hurts, the technique you use for locating? Some people talk about following the gas down the cecum.
Oh, the technique, yeah, I didn't really get into that. It's called mowing the lawn. And so what you do is, I start in a transverse plane, and I do this kind of zigzaggy thing over the belly. I just go side, down, over, and then I go sagittal, and then I go this, and then I go up, over, up, over. I just keep going in this kind of mowing the lawn, right lower quadrant, covering a lot of territory, compressing every centimeter as I go. So I start transverse, and I just compress, move, compress, down, compress, move, down. And I just keep doing that, sagittal transverse. Graded compression technique in the right lower quadrant. Does that make sense? Same thing with small bowel obstruction, frankly. You're just moving around the belly and compressing. Yes?
Great to have you. Thanks for the talk, was great. Now, in your department, if you find the clinical appendicitis and confirm with the ultrasound, how comfortable are surgeons to take that patient to get a device scan?
Great question. So how comfortable the surgeons? It depends who does the study a little bit, how confident the clinical sonographer was down in the ED, and also depends on the surgeon. But we can admit the patient to their service and start some antibiotics and kind of move the patient through the system. Surgeons come examine the patient, they see our images, and some of them will take the patient straight to the operating room. Some of them want CT scans. All depends on who the surgeon is and who the doc is in the ED.
So you have this problem?
Yeah, of course, yeah. You have the same problem everywhere, but that's okay. Pediatric surgeons hate CT scans. Adult surgeons love CT scans. We generally tend to observe in our patient population.
How successful are you at picking them up when you've got large BMI patients?
Yeah, the BMI thing is definitely more difficult. All the studies show as the BMI goes up, the accuracy of ultrasound for appendicitis goes down, for sure. And so, but the more you do it, the better you get at it. And when you find it on a patient with a large BMI, you feel so good about yourself. It's like you just won the game. It feels really good. So I say keep doing it. You'll get better. It makes you stronger every time you try to do this, even if it's a large BMI.
It takes longer on a bigger BMI person, time-wise, or do you think that that's related more to your level of experience in terms of just your scan technique and your confidence level?
Yeah, both things are important here. BMI and also your level of confidence in your technique is important. I think certainly larger BMI, these things take longer to do for sure. You have more ground to cover, and patient positioning is important. That's the other thing I didn't mention is that I have the patient cross one leg over the other when I'm doing this. When you do an aorta scan, right, you have the patient bend their knees so you can push down really hard. When I'm doing an appendicitis scan, I have their legs crossed, so it kind of brings the contents a little bit more into an anterior posterior plane, which is better for compression.
That's a clever
I forgot to put that. I had that on one of my slides. It fell off.
No,
Again, I never know what I'm going to talk about until I stand up here, and then this is what came up. So, no kidding.
sounds like great. Cool. All right, thanks, Chris.